Welcome back to Daybreak. This is the show that brings you what you need to think about as you begin your day. And of course, being Tuesday the 15th of January 2019, we have time to talk to the Cabinet Secretary in charge of health, that is Sicily Kariuki. Thank you so much for making time for us.
Thank you for having me.
And Happy New Year.
Happy New Year.
How is it so far?
No, so far so good. Yes, high tempo. Yes.
Even at the ministry?
Oh yes, I've been in the office last 2 weeks, more or less. Watching over how we are performing in UHC pilot counties, but also planning for the year ahead, which has to be better than last.
Yeah, it has to be, because you have to keep improving.
Absolutely.
And that's why I want us to begin from the universal healthcare that you're piloting in 4 counties: Kisumu, Isiolo, Nyeri, and Machakos. And of course, there are various reasons that you arrived at in picking those 4 counties. And yesterday I spoke to the governor of Machakos. He told me that so far they have registered about 700,000 individuals out of a target of 1-point-something million persons in those counties. Let's just understand, basically, once you register for universal health care in Machakos County, for instance, the citizens accessing these health services free of charge. What is the long-term goal once you're okay with the pilot, now you roll out to the rest of the country?
Well, thank you very much. Very useful question. The reason that we wanted to take an approach that got us piloting before we took ourselves to scale was we realized there were gaps in service delivery. There were weak systems, if you will, in terms of delivering health. But importantly, going to 47 counties all at the same time would have had inherent challenges. And consulting with the governors, other stakeholders, it was felt that it would be important for us to use a smaller population so we can learn. And as we learn, then we are able to, when we go to scale, to make more sense and perhaps avoid failures. We've seen other countries get started at scale. And when challenges come, then it means actually you are exposed across the board. So that is how we reached the decision of taking that as an approach. And I think it's yielding, it's paying, because we're already picking useful lessons that then we are going to deal with, and the gaps that we're already dealing with, so that as we go to scale, then I think we are better prepared, and that there is a common understanding. It should be understood that universal health coverage has the citizen, the individual at the center in terms of also helping deliver quality health care. The approach we are taking, therefore, means we have to carry everybody, from you, the individual, all the way to the gatekeepers, who are the leaders in the counties, and certainly at the national government level as well. Right.
And so from what I've been able to read from the ministry's website and the and the plan is that you will pilot for about 6 months. Then after that, you start to roll out to the rest of the country. Is that still on course? And I understand that the launch was on the 13th of December. So 6 months expire about May 13 or June 13. So is that still the plan? And how are you gearing towards that?
Now, the timing that we have given ourselves is between 6 months to 12 months. Every month, we have just done the first 1 month. Every month we are picking lessons. Every week we are picking lessons. Some are confirming that what we are doing and the approach that we are taking is right. Some are confirming that there are still gaps, and then we are having to deal with that. For instance, I would be able to say last week my team was out in the field monitoring together with the teams in the 4 counties. One of the things which comes out is that we are still not respecting the referral mechanism. That a patient will move from the closest facility to them and move actually all the way to the, to the level 5, what we call the highest level hospital. In Nyeri, we have one which is in Nyeri town. You'll have somebody coming all the way from Chinga and actually, using fare, coming all the way. Why? It's because in the past, it's possible the closest facility to them did not have the drugs which they require, or the the healthcare attention was somewhat not what the level that they would be expecting. So we are picking that, and of course continuously having a conversation with the population so that they know that you can be able to get quality care at the facility which is closest to you.
We'll get to the referral structural system of the country later, but first, so you are giving yourself 6 to 12 months to review these, but the ultimate goal, because universal health coverage is about accessing quality and affordable healthcare. So you do not expect that the government will be financing this free of charge in the long term. So how exactly do you plan to do that?
Right now, what we are doing, we are actually moving commodities largely through KEMSA into the facilities, direct to the facilities. We are also moving additional resources which are going to address issues at the community level, the primary health care level. Ultimately, we must be looking at system strengthening, institutional strengthening, coming up with a legal framework that allows for us to strengthen our social health as a mechanism to deliver. And this then means that NHIF, again, will come to the center in terms of delivering that. Countries that we have studied are countries that have used this because it's a more sustainable model, where you and I can afford to pay for healthcare, then we'll be encouraged, as the law requires, for us to continue paying. Those that cannot afford to pay and get ill are likely then to utilize the resources which you and I will have contributed. That is a more sustainable model. Okay.
And so health being devolved functions, so primarily the counties would have the responsibility in ensuring how the health facilities are working and even employing the healthcare workers. So as you do this, where do you stop? Where do you draw the boundary as you give the policy direction as a ministry, and where the counties need to take over?
It's good to make an observation that from day one, in terms of planning, the minute the president pronounced himself on his Big Four agenda, and the UHC was one of them, conversations between my office and the governors through the COG commenced. So the planning process is the consensus around piloting, the consensus around who does what has been built over time. We've had a very engaged time the whole of last year before we went on to the launch with the counties. We do realize is a devolved function. So what we are coming in to do is to lend some additional support, but also setting the policy direction as you indicate, and bringing in the legal framework as well as the institutional reforms that are required to be able to support the longer term realization of UHC. So it's a joint journey. Clearly, service delivery belongs to the counties. Okay.
So the Kenya Medical Services, KEMSA, is it authority or agency, is supplying the drugs straight to the health facilities. But apart from drugs, the other challenge that faces the health sector is in terms of the health workers themselves. So the last time we checked the statistics of doctors in the public institutions of between 5,000 and 6,000. Of course, the nurses, they are more, but what comes out from the counties is that they don't have enough doctors or enough health workers. So for this universal healthcare to succeed in terms of quality, they will need that. So how would the ministry facilitate devolution of more resources to the counties to further this?
Clearly, we have a gap in terms of the healthcare workers that we require to be able to service a growing population. We are far from, getting to the target. The employer, as I have indicated, is the county. The service delivery is the point of the counties, and therefore the supervision and leadership and governance and all the frameworks at the county level belong to the counties, as it were. Issues of additional resources being invested, whether coming through the national level or direct to the county, is aimed at bringing in additional human resource capacity or capabilities. It is meant to ensure that there are commodities available through, be it drugs or non-pharmaceutical commodities in the facilities, but also ensuring the systems are set in place at the level of service delivery, is what we refer to broadly as system strengthening. And that issue of system strengthening actually belongs to the county, save for issues of capacity building, save for issues of training, save for issues of setting standards, save for issues of, if we will, supervising and having a monitoring and evaluation framework that helps us to learn and improve as we move along. So that is understood, as it were. But what we are doing from the national government level is we have done a needs identification across the board. We are coming up with a projection of the health needs and requirements, and therefore trying to match in months to come the training that we are going to be giving our health workers, matching that with the gap that we have already identified. So that will continue to be a conversation that we have together, but we know the issues of training and capacity building squarely belong to the national government, and we are working on that. Up to and including coming away from the level of conventional training to come and say we can train our specialized doctors using online modes and what we call the collegiate mode of study. And we've already built consensus around that. We agreed because we need to speed up the numbers as we move forward.
So, Waziri, there are certain strains or complications that are affecting this country increasingly now. For instance, the non-communicable diseases, talking about cancer, talking about diabetes, cardiovascular complications. For instance, if it's cancer, now we understand there are 47,000 new cases every other year. So how does the ministry plan to focus on these institutions, in as much as it is the role of the counties? There's the aspect of complicated cases, which most of them find themselves at the national referral hospitals. How then do we improve access to healthcare for persons who are suffering from these conditions?
I think it's good to have a conversation which is being two-pronged around the non-communicable diseases. Cancer is one of them. You cite cases where we are recording up to 33,000 cases, deaths reported directly because of cancer. We have diabetes, again, very growing in terms of importance, but we also have hypertension and also mental illnesses. All those belong to that non-communicable diseases, not to mention diseases that come as a result of accidents on the road. We have come with the proposed strategies on how to tackle each one of these non-communicable diseases. And beyond the strategies, there is need for additional investment. And that is why in the case of cancer specifically, we have an action plan to execute a strategy which calls for us to be able to put up cancer centers of excellence away from the center, away from Kenyatta and away from Moi Referral Hospital. And indeed, we have earmarked counties such as Nyeri, Mombasa is also earmarked for that, Nyamira, Kisii, pardon me, is earmarked for that, so that we then are able to devolve, so to speak, specialized cancer care to the counties. And so the national government will invest in those facilities. But important is also to have specialized doctors, oncologists, that would have a better population than what we have currently. And right now we have a good number out training, so that then they can be able to come and be able to give the care that we require. But the additional conversation that I needed for us to have is that some of the cancer cases are actually preventable, particularly if detected at an early stage. And that is why the approach we are taking on UHC today is not one that allows for you only to access healthcare at the hospital. It is one that at the community level, at the household level, you are actually able to do a few things that would then help you to maintain or to have good care. Early screening becomes very, very important for us. In early screening, we have had cases that are detected early enough and treatment was given and you came through and actually got well. So we are encouraging for us as a population to look at what we call preventive and promotive health care, so that then we don't have to all be walking towards or moving towards hospital for care. That becomes very, very expensive.
And so with that, I have two questions, but let me start with this. We have CHVs, community health volunteers that you have engaged to help in this preventive health care. How does that work?
The issue of engaging community volunteers is actually not a new one. We have had to get the ones who were trained previously and trained to be able to understand the basic community or population health services that can be given by people who have not necessarily gone through training the way we know it. The nurses, for example, 2 years. But here we have a package which comes in about 13 modules. A curricula that has been adopted by the sector previously, and where we have trained right now up to 75,000 community health volunteers in the past. Now, the word volunteer means they actually do that. They volunteer. They remain within the county, within the community where they belong. Pretty much you can liken them to the Nyumba Kumi initiative. They belong there and are attached to households. And what they do is to check where they are the young children in a household. whether has a child taken on immunization, and if they hadn't, it is their business then to remind you and ensure that you actually access immunization services. For the expecting mothers, again, is for them to check and see whether you have commenced accessing your antenatal care. And if you haven't, again, it's their business to remind you, but lead you on to the facility. So they are linked to the facility where they refer you in a lot of ways. So when we are doing outreaches around diseases such as malaria and want to educate, they also become our educators. When you're looking at issues of nutrition, early screening, again, they become that person who reminds you. I want to, again, just reiterate the fact that they are not your usual person walking on the street. They have been trained and they have gone through 13 modules where then they're able to understand what is good nutrition about. They're able to understand what is the importance of immunization and childcare. They're able to understand the issues of why you need to access care as an expectant mother. And so they become an invaluable asset in terms of giving community health at that level, where also we need to do public health activities, clearing bushes, dealing with stagnant waters. Again, this is the army, if you will, that identifies those gaps and mobilizes the community. The conversation we have reached, again, we have an elaborate community worker strategy. We have reached a position where most of the county governments are actually now domesticating this strategy to be able to adopt it, to be the approach that we take. It yields much. We have looked at countries who have used this approach. It yields much because he's somebody who belongs to the community. So the believability rate is very high. If they say we have to immunize the children because of 1, 2, 3, then the issues that we have seen in the past become managed quite easily. We've also agreed with the governors that they will be setting aside some minimum budget to be able to actually pay for them, allowance for them to be able to move house to house. And we've agreed that the minimum, once they have been put on this work, the minimum hours they'll put every day would be about 2 hours. So then they can confirm and help us to realize better health outcomes. So
for the 2 hours, is it the national government to pay for it, or it's the county government?
It's actually the county government. The county government.
Okay, all right. And the issue that you focused on, that you touched on, that you're building cancer centers of excellence in Nyeri, Mombasa, and Kisii, do you have any timelines, like when they should be operational?
Kisii is close to, if you will, commissioning. Hopefully within the month. Nyeri, we have only now gotten the resources being availed. So again, we'll be commencing putting up this particular one. My own ministry, we have some resources that will be looking to do some bunker, then getting the equipment in the coming financial year. But important to note also, besides the elaborate cancer centers of excellence, we've also invested in other equipments, the cancer, if you will, chairs. We've invested in mixing hoods. We brought in some drugs, and we have distributed them to several of the hospitals in the counties. That already is happening, where then we have chemo being administered in some of these facilities.
Sometimes last year, when I spoke to the county executive committee member in charge of health in Kajiado County, she spoke of the difficulty in making use of the equipment, the medical, what is the program? Medical listing.
Medical equipment service.
Yes. And she talked about that they have now to spend up to 200 million shillings for the listing program. And they felt that they have resources that are not exactly what they needed for that county. I don't know how far this has come. This discussion has come with the governors, of course, sometimes expressing their dissatisfaction. Some other counties, they're yet to fully utilize those equipment because they do not have the space, they do not have the workers, the specialized workers. How has this conversation gone between you and the governors?
This conversation has been completely misunderstood or taken out of context. The governors do not pay, not 1 shilling, not even 200 million. I think that is where we should start. The Managed Equipment Service is a program by the national government where through a conditional granting program, the equipment have been availed to the various counties. Phenomenal work in terms of health outcomes. positive impact in terms of the patients who have been affected or who have had the reason to utilize these equipments. Personally, I've witnessed many cases where patients would otherwise be covering 250-kilometer distance, moving from Lamu all the way to Malindi, or moving from Lamu all the way to Mombasa. Patients are able now to get the services at the spot. And that story is replicated if you go again to Turkana, where we had maybe 4 months ago the commissioning of these equipments. Patients who would otherwise go to Eldoret from Turkana, you can imagine that distance, actually being able to get dialysis, which, as you know, is a very regular kind of care that you have to get when you have a kidney problem.
Sure.
Having now stopped spending fare to go and time to go to Eldoret, where in a few cases those patients have had to move with their relatives to actually go and live in Eldoret. So that has come to an end. And so in a few instances where we actually don't have a few of these equipments functioning, one, because the voltage, the power availability was not quite adequate, or where we have had cases of the theater, the nurses not being there in their numbers. We have registered a few of those cases, and we are doing everything possible to ensure that, one, we get the skills that is required by the counties to make sure that they're operating at 100% level. Yes.
All right. When we talk about, there's someone who is asking a question, I'm trying to retrace it here, and they're asking, with this universal health care, how do you access services at private facilities?
Okay, good one. At the pilot stage, we have restricted delivery to the public facilities only.
Yes.
Why? I'm sure she would ask if it's a lady. It's because we realized there were gaps in the systems. And so we decided part of the system strengthening was for us to invest in the public sector, where we had more gaps than we have in the private sector. Number one. Number two, we also did realize right now with the current NHIF system, most of the investment and reimbursements are actually ending up going to the private sector. And so we thought we would take this opportunity also to strengthen the systems in the public sector. Again, through consensus, and we thought that is a better investment. So that when we go to scale, then we are able to look at the public sector vis-a-vis the private sector and have both of them being available to serve Kenyans.
Okay.
So for the time being, we remain in the public sector.
And it's not her, it's Victor from Mombasa.
Okay.
but it's okay, the response is well taken. Then when you talk about, let's get back to the referral system of the country. When you go to the Kenyatta National Hospital, you'll see that even basic complications or basic ailments have been taken to that referral facility, yet the understanding should be that you should begin at the lowest level if it's a dispensary or a health center. So what do we do as a country to strengthen that system? Because many people say that I want to go to a KNH because I know I can get quality health care. What do you do to ensure that people can trust and can access quality at the lower levels of hospitals?
It's a bit simple. We just have to make sure we have commodities in the lower level facilities. We have to make sure we have health workers. We have to make sure that the governance and supervision is happening. We have to make sure the lead time is not very long when you go to the lower level facilities. On the one hand, and that belongs again to the investor, who is either the national government or the county government in most cases. But importantly, it is you, the Kenyan citizen. It is your civic responsibility to ensure that you do not go to a higher level facility bypassing the lower level facilities just for the sake of. In a few cases, we have seen countries where actually if you bypass in terms of levels 2, 3, 4, and 5, up to 6, which is Kenyatta, if you bypass, actually you are going to be punished. You are going to be penalized. You either pay double the charge if you have to pay, or you are referred back to go and seek care at the level which belongs. And we may have to just go there. But because we are piloting so that we also use this opportunity to speak to Kenyans, we want to believe that time that we are having as we do pilot will be a chance for us to also speak to all Kenyans so that we understand what are the merits of taking a flu to Kenyatta Hospital when indeed somebody who requires specialized cancer care, you are taking their time, and that is the opportunity that belongs to to save their life. So I think with the continuous engagement, I want to believe Kenyans are responsible people. They just need to know what is the rationale. And this is one of the things that we are picking even as we pilot. Still people bypassing in terms of levels. If it's not too complicated, you will kindly be referred back. And this we will do.
Is that happening?
Yes, that is happening. That is happening.
Well, that's a good point. Yeah. And then the other question is about, like, one of the challenges that people are facing. When I was in Kajiado County, I was told by some of the residents that if they are in Loitoktok, the referral facility for that county is Kajiado County Referral Hospital. It is kilometers, hundreds of kilometers away from them. So they would have to go to nearby institutions, for instance, in Makueni. What is the framework of the Ministry of Health in facilitating that? Must they be restricted to referring the cases to their county referral hospital, or they can do cross-referral to different other counties?
Ideally and long term is that you should be able to do cross referrals, and the governors are across, sharing borders are actually in discussions around this, because it is only fair. The reason that the national government puts additional conditional grants to the county referral hospitals is because we realize populations are going to cross over from this county and cross over to if it's nearer to you. And so that is why we invested in additional resources in the referrals. But ideally this will be solved if we come up with if you will, a system where on IT, then you are able to reference and are able to make settlement. And we are working on that as well.
Okay. There's someone who's saying here that, what is it? Speaking of Kenyatta National Hospital, the MRI machine has not been working for a long time. People like inmates cannot afford to go to private hospitals. What is being done to fix it? And the question, therefore, I want to globalize it and talk about there are systems downtime in any facility. So when, let's say, at Kenyatta Hospital, the equipment are limited to maybe 1 or 2, and then the downtime, what is that strategy that hospitals need to put in place to ensure that they do not suffer and affect the lives of Kenyans that depend on those machines?
One of the advantages I have found with the managed equipment service personally is that you pay on the time that patients are accessing service on the equipment. So the downtime is not charged. And if you go beyond a certain percentage of time on downtime, then we penalize you as a ministry. And it's a useful thing that we have picked. And I want to encourage whoever else is investing, because I'm also aware the counties are investing in equipment, to borrow some of these positives from the managed equipment service, so that then we don't have equipments which are either lying there not being useful, yet we are going to be paying for them. Right. If the Kenyatta case you mentioned is one of the managed equipment service, and I'll be looking after this, it is possible then the contractor will have to pay for it. And that is an advantage for me.
Right. But obviously you understand the questions that people have of public facilities that not all the time they'll be efficient, or even because of the congestion at public facilities, that's why they prefer to go to the private institutions. And so now with universal healthcare, you at the pilot stage in ensuring that services are offered at the public hospitals. But in the long term, so that if you don't want to be attended to by a public hospital, you want to go a private hospital because it is your right, how then do we make it more affordable so that people do not have to suffer the setback of finances in this country?
By the way, even right now, if you are holding the super cover, the 6,000 cover from NHIF, you are at liberty to access care even from the private sector. The restriction of the pilot right now is also because we wanted to apply a stressed test to the facilities in the private sector and in the 4 counties. So it was very deliberate that we see how would the health system respond under stress conditions, including the entire population, 3.2 million accessing services only in a space which is contained. Because again, pilot is a study, so we are studying. We've had to make other conditions.
Right.
But long term, like I did indicate, we see ourselves also bringing the private sector to be part of this sustainable, long journey. Remember, it's a journey we begin now. It's an ending. It's going into the future. It's going to outlive all of us.
Right.
Yeah.
So I want us to briefly spend some time talking about the case of Makueni County. But before we do that, you're piloting in 4 counties. There are 43 others. What are they doing in the meanwhile?
Meantime, every one of the governors has committed and is busy working on system strengthening. They are looking at issues HR. They are looking at issues flow of commodities and non-pharmaceutical commodities. They are looking at issues of putting up the committees that are required. So they are looking at the governance issues around there. They are looking at issues of infrastructure, rehabilitation where it's required. They are looking at issues of equipments. And here I'm not speaking again about those very elaborate, huge equipments. We are looking at basic equipments, but they are also looking at the lower level facilities. Like I did indicate, the approach we are taking in UHC in Kenya today is one which is going to be primary healthcare driven. By that I mean we are not going to be starting by climbing a tree from the roof, from the top. We will start from the basics. The community services become very important. Public health becomes very important. The lower level facilities, what we call the dispensary, the healthcare, become extremely important. So the governor is busy looking at seeing what additional work and investment is required at that point. In other words, system strengthening. But we are also having to look at what they are doing in there. And by the way, making sure we also train the community health volunteers across the country and retrain them so that some of the issues where we've had to run overtime as we were planning last year, by the time we go to scale, we already will have done a bit of the foundational issues that are required to be done.
Right. With the case of Makueni County that has been trying this out for a couple of years now, where every family has a card, I believe an NHF card, and they make a contribution of a minimum of 500 shillings every other month. Are there any lessons you've picked from Makueni that would be important in replicating in other counties?
Absolutely. I mean, I really want to commend Makueni. Kitui also, which is following suit. We are also comparing notes. We are checking what it is they are doing. And by and large, as we learn where we have intensive presence and where we have programs, some certain parameters that we are looking at, we'll also be looking at what's happening in Makueni, what's happening in Kitui, but we'll also be looking at what's happening in all the other counties. You know, we ain't leaving any county behind. It's just that we are doing different things in different counties. A lot of intensity in the 4 pilot counties, a little bit of system strengthening and capacity building in the 43, including Makueni and Kitui, and comparing. Like I did indicate, we have regular consultations with the COG, and we'll continue to compare notes, which brings me to the point of wanting to really commend Governor Nanok and Governor Kuti for leading us and joining us in the planning processes last year, but also wishing the incoming Governor Oparanya and the new leadership team well, and saying that I'm looking forward again to continue the journey. Remember, we are in class, we are learning, and we'll learn together so that when we go to scale, then Kenyans can get what is their right, both in terms of access, both in terms of quality, but also affordability.
Comment from Eldred is saying that a universal health coverage can work if all Kenyans focus their minds to reduce the hurdles. Sensitization should be a duty of Kenyans of goodwill. Elected leaders should be urging the electorates to register, especially in the pilot counties, so that at the end of it, clear lessons can be picked. You know, healthcare providers must focus in minimizing waste when rolling out UHC. Waziri, you have my prayers in this noble journey. That's coming from Eldred. But I think the question I want to ask you is in as far as when eventually we roll all this out, what do you estimate the cost will be?
We are working on a modest budget of 3.9 billion now in the 4 counties. 3.1 of those resources are going direct into the counties. 300 is going into coordination, monitoring, evaluation, any corrective actions, capacity building from, from my office. 500 is going into a specialized fund which will cater for the complicated cases from these 4 counties where we see an opportunity for some of the very sick patients to come to level 6. That level 6 then need to be also facilitated to be able to cater for them.
Sure. As
we go to scale, if we use the same model, we have a projection of resources that go just in the range of 40 billion shillings. Now, that is assuming we are following the same model we are using now. Certainly, if we go back to our original thought, which was through the more sustainable social health scheme, then we'll have to do our computations and be able to see how that is going to look like. I estimate that to be in the next 2 years.
Okay.
Yeah.
So these resources will be directly sent to the counties or still managed from the national level?
Right now we've agreed that we'll manage them. We make the decisions jointly.
Okay.
Every one of the facilities require drugs. They require amphetamine, they require syringes, they require, gloves. So we've agreed, as opposed to taking the money direct to facility, then back to procure from KEMSA. I think it makes sense that you procure what has been identified by the counties themselves directly. That is what we've agreed. A big portion of the money, 30%, is going direct to the counties to do what we call O&M.
Okay.
Yeah.
What is that?
Operations and maintenance in the facilities.
Okay. It's a good point for the sake of the view at home. So thank you so much, Waziri Sicily Kariuki. I don't know whether they have any final remarks to make. Asante
sana. No, just to remind Kenyans that health is not about government, it's not about your county government. It's about you, it's about me, it's about the government, all of us working together. And including the civil society that has been quite useful in inputting in the planning processes. But I also want to appreciate the county government. We recognize a devolved function is one that works, is one where there is also talking with each other, speaking with each other, listening with each other, and planning. And that is how come we've come this far.
Okay. Has this process been peaceful with the workers, the health workers, the doctors' unions, and the union for nurses?
So far, so good. I think we do recognize we owe it to Kenya.
Okay.
We owe it to Kenyans.
All right. Thank you so much for making time for us on Daybreak. Waziri Sicily Kariuki, in charge of health.
Asante.
That's all the time that we had to discuss about universal health coverage and other matters. Wish you very well as you continue to roll this out. Of course, Daybreak now takes a short break, but we'll be back with Willis Raburu and his panel of two guests talking about engage the issues that we may have. You'll be sure to send them through to 22422 or Twitter's at Citizen TV Kenya, and the hashtag to use is Daybreak. Back in a moment.